patient's platelets, the prolonged nosebleeds, the multiple ecchymoses, one major thing to remember when you're talking about common variable immunodeficiency is that this presents very frequently with autoimmune phenomena. Particularly, the big one is ITP, which is immune thrombocytopenic purpura. We talk about this a lot in the heme section, right? And that's exactly what's going on here, most likely, right? This patient also, a lot of these patients with common variable immunodeficiency will present with like ITP, or another big one is autoimmune hemolytic anemia, right? They'll present with these symptoms, and then this will get treated by a hematologist, and then this will kind of be incidentally discovered later on that they have common variable immunodeficiency. So just kind of keep that in mind. Very frequently in board questions, they'll kind of integrate these different concepts to try to throw you off. But as long as you kind of understand the big picture, what's going on, you can read through some of this lab data, then you'll probably be okay. This is a very high yield section where a lot of the different questions are going to stem from. So what's really important here is that we get down the differences in the mechanisms and then some of the very classic disease processes that present with each of these 4 different hypersensitivities. So we'll start at the top and work our way down through the different types. So when we're talking about the type 1 hypersensitivity, we're typically going to be talking about more of an allergic type of reaction. And you can see, allergic contact dermatitis, for example, with type 4 hypersensitivities. But in general, when we're talking about allergies, allergens, we're talking primarily about type 1 hypersensitivity. Okay. Now, in this category, the classic causes are going to be patients that are allergic, again, to certain foods, right? So again, we're talking about allergic. So patients that are allergic potentially to certain foods, to certain medications, or a history of some type of insect sting, all very classic for this kind of allergic reaction. And the concern when you have these allergic reactions is that this allergic reaction can kind of tip the patient over into anaphylaxis, okay, specifically anaphylactic shock. So that's what we're worried about in these patients. We don't want them to get to the point where their blood pressure drops and we don't have organ perfusion, right? Because of this massive widespread reaction. And that's where the name comes from, right? We're hypersensitive to something, whether that's, peanuts, shellfish, certain medications. The classic one, when you're talking about medications, these patients can be allergic to penicillins, they can be allergic to cephalosporins. But for each of these categories, there's usually like a classic drug that fits into that type of hypersensitivity. You'll see what I mean as we go through this. Sulfa drugs are going to be very classic for the type 1 hypersensitivity. That's not to say that you can't get certain other types of hypersensitivity reactions with sulfa drugs, but kind of the classic one, when in doubt, is going to be more of the type 1 hypersensitivity. And then insect stings, certain foods, very, very classic for causing these kind of allergic reactions, these type 1 hypersensitivities. So what exactly is happening when you have a type 1 hypersensitivity reaction? So let's go through that really quickly. So the thing that you really want to understand here is that there's 2 kind of steps to this. There's the initial exposure and then there's the subsequent exposure. Okay, so let's start off with an initial exposure. Okay, so the initial exposure we're going to kind of just do in this green color here. So we're going to start off with some allergen. Okay, now an allergen, you might be saying, what's that? An allergen is essentially just an antigen. And we've talked a lot about antigens up to this point. So you can essentially think of the allergen as an antigen, just to keep things simple, because that's really what it is. Okay, so it's some antigen that's floating around in the blood. Now let's just make things simple here. So we can just say that we had a patient potentially here that just got, some insect sting for the first time, right? They got a bee sting, and our patient with the bee sting, when they had this inoculation of the sting, there was some allergen from that sting potentially that eventually got into the body. Now, this allergen is going to get recognized by the antigen presenting cells. And this could be antigen presenting cells in the skin. If we're talking about, inoculation from a sting, it could be antigen presenting cells in the blood if we're talking about a reaction to a sulfa drug. In any case, we have an antigen presenting cell. It's going to recognize this allergen and it's going to bind it, right? So it's going to bind it. It's the unique fit on its receptor to bind this allergen. This antigen presenting cell is then going to go on to bind to some naive T cells and say, hey, look what I found. And remember, this T cell receptor is going to be complementary in terms of its binding to this antigen. And what type of receptors are we talking about specifically here? So we have our MHC2 receptor. Okay, now you might be saying, well, how did you know that was MHC2 receptor? It's an antigen presenting cell, right? Antigen presenting cells will display MHC2 to bind to antigens. Remember, all nucleated cells also have MHC1. But for this antigen presenting cell to display the antigen on MHC1, that antigen presenting cell would have had to have been infected, or we might have something going on inside the cell that would cause it to present an MHC1 through the endoplasmic reticulum, right? And those are all things that we've already talked about, so I won't go into too much detail on that, just kind of bringing it full circle here. But again, because this antigen-presenting cell recognized this extracellular allergen, it presented it on MHC2. And if it's presenting it on MHC2, then this naive T cell that recognizes it must recognize it on a T cell receptor that has a CD4 positive co-receptor. How did I know it was CD4 positive? Remember your rule of eights. 2 times 4 is 8, right? MHC2 times 4, that's 8. This is a CD4 positive T cell, and this is where I want you to just stop for a second, because this is where test writers can trick you very easily, right? Because they can say, look, type 1 hypersensitivities, what are you thinking about? You're thinking about antibodies. In general, when we're talking about hypersensitivities, the first 3 types of hypersensitivities are all going to primarily involve antibodies, okay, immunoglobulins. But when we get to type 4, the type 4 hypersensitivity, we're going to be talking more about T cells. Okay, so the question is are T cells involved in a type 1 hypersensitivity? The answer is actually yes, T cells are involved. This whole process is going to be primarily antibody mediated, but to get to that point, to get IgE antibodies, which you'll see in a second, we need T cells. Okay, so don't be fooled. You still need T cells to make IgE antibodies. You can't class switch, right, without T cells. We've gone through all of this a few times, in the video series so far. So again, I don't want to talk too much about that. You can go back and check out the other videos, but that's the concept. Okay, so we still have T cells involved in some way. All right, so let's recap. So we have some allergen bound to this antigen presenting cell, now presented to this naive T cell. Okay, and now once we have that presentation occurring, that T cell then becomes activated. That T cell, what it will do is it will find a B cell, again, with the same kind of receptor binding to that allergen or antigen. And we have our T cell receptor here, right? So we have our T cell receptor again, T cell receptor, and then here you can see this immunoglobulin on the B cell. Now, what's this thing down here? This is going to be a very important CD40 ligand, right? So here's your CD40 ligand, and here's your CD40. And again, we talked about all of this in the previous videos. This is going to be responsible for that co-stimulatory signal, so we can get class switching to occur. We get this signal, interleukin 4 and interleukin 13. Now remember, these are high-yield cytokines that are responsible for class switching from IgM to IgE antibodies. Okay, so now you kind of see where this is all coming full circle, why IgE is so important in this type 1 hypersensitivity. In fact, I would go as far as to say that IgE in general is probably the single most high yield thing to remember when you're thinking about type 1 hypersensitivity. Okay, so we make these IgE antibodies from interleukin 4 and interleukin 13 from class switching, right? Now, those IgE antibodies, what are they going to do? These IgE antibodies can then bind to the surface of our mast cells and our basophils. So it doesn't just have to be a mast cell, it could be a basophil here too. But the point is that these IgE antibodies are going to bind to the mast cell and basophil. And you can see what portion is binding to the mast cell and basophil. This is where the devil's in the details kind of thing, right? So these receptors here that you can see, this red-orange receptor, that's going to be the Fc epsilon receptor, okay? And it kind of sounds complicated, but the way that you can kind of think about this is Fc, right, is just talking about this portion of the antibody. Remember, you have your antibody, and remember, this portion is your Fc, your constant region, and then you have your Fab region out here. Okay, so this Fc is just saying that, hey, this receptor binds to the Fc portion of the IgE antibody. That's really all it's saying. And then the epsilon, I just remember epsilon with IgE, right? Epsilon receptor. Okay, so that receptor is on the mast cell. That's this structure right here. Okay, so that receptor is going to bind to, again, the Fc portion of the IgE antibody, meaning that the Fab portion of the IgE antibody is going to be sitting out on the top of the cell. So when an allergen or antigen comes around in the future, it will bind to this Fab region, and when it does that, these IgE antibodies can cross-link, causing degranulation of your mast cell. Okay, so all of this stuff in green was the initial exposure, right? We got these antibodies put on the surface of our mast cells, of our basophils, all because of this process, because we were, stung by a bee, for example, or we took a medication that we were allergic to, right? And the antigen presenting cell presented it to the naive T cell and caused this cascade to happen that ultimately resulted in sensitized, that's the key word, mast cells and basophils. Sensitized because now they're sensitive to this allergen. So if this allergen were to come in the body, again, if I got stung by a bee a year later, right, or if I took that medication a year later, I'm going to have a a much worse reaction, because now all of these IgE antibodies that I created are sitting on the surface of my mast cell and basophil. So this is going to be the re-exposure. We'll do this in purple. Okay, so this is the re-exposure. So now I'm being re-exposed to this antigen, right? This is a second time, or maybe a third time or fourth time, but you can see now these mast cells are already prepared. They already have the IgE antibodies that we formed from class switching on their surface, causing degranulation. And what are we degranulating here? This is going to be primarily histamine, okay? That's going to be the big one to remember. And you have to kind of remember, what are the effects of histamine? So histamine can cause bronchoconstriction, bronchospasms, vasodilation, and can cause increased permeability in the capillaries, so you can get some edema, right? And those are some of the features that we see clinically. The big, presentation thing to look for is going to be urticaria in general. Okay, so urticaria is very classic for type 1 hypersensitivities in particular, or some kind of allergic reaction that's kind of disseminating throughout the body. Now, urticaria is also sometimes called this wheal and flare type presentation. So that's another kind of term you can see is wheal and flare. And the wheal is going to be kind of these areas of central pallor, where we get whitening essentially. That's the wheal. The flare, right? You think fire, flare. The flare is the red area around the wheal. So it's all of this red area, right? That's going to be around those areas of pallor, those wheals. Okay, so that's the wheal and flare. And this lesion is actually going to be raised a little bit. And that's because we're getting a lot of fluid in the superficial dermis, right? So as we have increases in vascular permeability and vasodilation, we're getting fluid leaking essentially into the superficial dermis. So that's what urticaria is. Now just be careful here too, because there's also angioedema, which you can also see here because of the vasodilation and vascular permeability. One technical kind of aspect to this is, remember, urticaria is going to be, we have fluid in the superficial dermis, where when we're talking about angioedema, we're talking about fluid deeper, usually in the dermis, usually in the subcutaneous tissues. Okay, so just a little thing to remember, when you're talking about the two of these. Now, like we said, the concern is that this can eventually lead to anaphylaxis, anaphylactic shock. Okay, so that's why this is taken extremely seriously. The even more concerning part is that it happens so quickly. So remember what I said, right? If you have a re-exposure, you already have everything set up for this patient to just degranulate their mast cells and their basophils. Because you already have all these IgE antibodies set on the top of your mast cells and basophils, as soon as that allergen comes in, they're going to degranulate. So it happens immediately. So that's why sometimes the type 1 hypersensitivity reaction is sometimes called the immediate hypersensitivity reaction, because it happens so quickly. Everything's already set up. You put the allergen back in and you get instant degranulation. And then again, like we said, the concern is that can go straight into anaphylaxis. So that's why this is taken very seriously. All right, let's just recap the mechanism here. So pretty much what we talked about in the early stages of this happening, again, there's going to be some previous sensitization, which is all of this kind of initial mechanism that we talked about. And then what happens is you have the IgE Fc portion bound on your mast cells and basophils. That's exactly what we saw right here. That IgE Fab portion is going to bind to the allergen like we see here. And then eventually we'll have some cross-linking, right? We have some cross-linking that we talked about, and we degranulate and we release histamine. So we can see the degranulation here right after we have our cross-linking. Now, there's also going to be some release of tryptase. And you might be saying, well, what does that do exactly? Well, the thing that I want you to remember about tryptase is that we can actually do a serum sample for tryptase. Let's say that we have a patient that comes in, right? Maybe they were exposed to something they think they're allergic to, and you might be concerned that this patient is kind of moving quickly towards anaphylaxis. What you can do is you can draw serum tryptase on them, and this will give you an indication as to if they're in fact at risk of anaphylaxis. So that's just one thing to remember in terms of the diagnostics. In general, though, when you're talking about things like anaphylaxis, it's usually more of a clinical diagnosis. You're looking for things like urticaria, difficulty breathing, shortness of breath, edema, etc. Now, the thing that is a little bit less high yield than what we talked about here, but has come up occasionally, is the kind of what happens in the later stages. What happens hours after you're exposed to this antigen? Because remember, the early phase are things that are happening immediately, right? We already have everything we need to degranulate. But later on, we do get some release of prostaglandins, leukotrienes from the arachidonic acid pathway, and a lot of this is potentiated through eosinophils. Okay, now you can see when we went through this mechanism, I kind of skipped this step here where the B cell can go on to release interleukin 5. And remember, interleukin 5 is very classic for stimulating eosinophils and eosinophil growth. And that's exactly what happens. These eosinophils are just a little late to the party though. Okay, so when you get questions on type 1 hypersensitivities, remember, you might have an eosinophilia, but classically the eosinophils are going to be the late stage players in the game. Okay, so they're not going to be things that are happening in the early phase mechanism. That's probably the highest yield thing to take away from this. And these all eventually also contribute to to inflammation. And I think we already kind of talked about the presentation here. Again, generally the more mild presentation, which can potentially lead to this severe anaphylaxis if not treated. And typically when we treat these patients, it's usually going to be with something immediate like epinephrine. Now, if it's more mild, you can think about things like antihistamines, right? Because the problem is that you're releasing histamine, right? So if you give somebody an antihistamine, that should have some effect into kind of minimizing some of these more mild symptoms. And again, this sometimes will take a little bit of time to kind of kick in, and there's different antihistamines, there's different classes. Just know that a lot of what we're targeting here is primarily going to be at the H1 receptor, okay? And we don't have to go into too much more detail than that. Step 1 isn't very heavy on the management, but for step 2, we'll definitely go into more detail. But if we're talking about anaphylaxis, we need something that's going to work immediately. And so in those situations, we're talking about epinephrine. Now, the other thing in the diagnostics, remember, you can also do skin testing in these patients. If somebody comes in and they say, "Doc, I'm just allergic to something, I don't know what it is," you can test all different types of allergens on the skin. And essentially, you're looking for these kind of reactions, right? You're looking for urticaria, edema, swelling, etc. Now, the last thing on here, I just want you to remember, because this has been coming up more and more in questions, are these non-IgE mediated histaminergic reactions. So it's just like it says. It means in some way, we're stimulating mast cells and basophils to release histamine, but we're not doing it through IgE. That's the important point. So is it truly a type 1 hypersensitivity? The answer is no, but you should be familiar with these. You just should know that they're not using IgE to cause this type of reaction, because again, everything is really based on mechanisms for step 1. So the first one here is vancomycin. This is going to be very classic for causing the quote-unquote red man syndrome, which is usually due to a rapid infusion. If a patient gets a lot of vancomycin really quickly, you can get direct activation of mast cells, basophils, and get degranulation. Okay, but again, not mediated through IgE. There's no IgE. It's direct stimulation from the antibiotic in some way or another beyond the scope of step 1. The other thing on here is radioiodine contrast is also very classic for this. And then very kind of low potency opioids can sometimes do this. And again, the presentation for all of these, it can pretty much appear identical to, what we're talking about here. It's just not IgE mediated. So when you see a question with radioiodine contrast, low potency opioids, and all of a sudden that patient looks like they're having a type 1 hypersensitivity or maybe anaphylaxis even, right? Just remember that these are non-IgE mediated, because that's where the questions come in. Type 2 hypersensitivities, we're talking about basically an antibody in the serum essentially binding to host cells, and they're binding to the host cells through this antigen that's going to be on our host cell. So just walking through this mechanism, let's just say in this situation, our host cell is going to be our red blood cells, right? And we'll say that, there's some antigen on the red blood cell. Now, this could be because we have a certain pathology like autoimmune hemolytic anemia, for example, right? This AIHA, or this could be secondary to, a drug that we took. Maybe we took a drug that bound to the surface of our red blood cells and now is causing us to target our red blood cells. Okay, so let's just say for simplicity's sake that we took some drug, right? We took some drug, let's just call it penicillin, for example. So let's just say that we took some penicillin, and that penicillin had an antigen. Okay, that's kind of what you see here. So that's this antigen, and it bound to the surface of our red blood cells. Now, this antigen from the drug is going to be foreign to our body, and so we can generate antibodies against that antigen. And you might be saying, well, which antibodies are we talking about? Classically, when we're talking about type 2 hypersensitivities, we're usually talking about IgG or IgM. And again, you want to juxtapose that to what we talked about with type 1 hypersensitivities, where that was primarily IgE. Okay, so usually this antibody that's doing the work here, it's usually going to be IgG, but in some cases, it can also be IgM, although that would be a little bit less common. And so again, it's also important to know what's binding to what, right? So when I have an antigen, my epitope is usually going to get bound to the Fab portion of my antibody, right? My Fab portion, and then here you can see this is going to be your Fc portion. Okay, so again, I'm going to bind to this antigen on a surface of one of my cells. In this case, it's the red blood cell. And you can see, here's the antibody, right? There's the Fab portion. There's the Fc portion bound to this red blood cell, bound to the antigens. Now, what happens is when I start binding antibodies to host tissue, the body can think potentially that this structure is foreign. Similar to what happens if you have a bacteria, right? If you just think about, okay, if you had some bacteria here, right? You had some bacteria here and you wanted to target this bacteria. Well, on this bacteria, there would be antigens, right? We would target these antigens, and then we would have antibodies that would come in, similar to what you see here. And these antibodies would come in and attach to these antigens and essentially stimulate complement, neutrophil chemotaxis, etc. So all the things that we talked about in the last videos, the only difference is instead of targeting this bacteria, we're targeting our own cells, because our own cells have some antigen on them, either from a drug we took, from some genetic pathology potentially, right? Or some other things that we'll talk about. But that's the point. So the point is now we have this antibody bound to this antigen, bound to this host cell. And the questions come in where you have to know, well, what are the things that can potentially happen to this host cell? Okay, so there's really 4 major things. So let's go through those really quickly. So the first thing is we can go straight down that complement pathway. You can go back to the complement video, check that out. But essentially what we have here is we have complement binding. Remember, it's going to bind to the Fc portion of the IgG antibody here, and that can essentially lead to cell lysis, right? Eventually, if we get to the MAC complex, which is the terminal complement cascade, we can essentially use this MAC complex to essentially punch holes into this red blood cell and destroy it. Okay, so that's one option. So by having these antibodies attached, we can have complement cascade stimulated, and the terminal endpoint of that would be the membrane attack complex, C5b to C9. Now the other option here is, remember, as I'm stimulating complement, I can also end up with opsonization, right? So instead of going to the terminal component of this membrane attack complex, I can stimulate C3b specifically, and C3b can then kind of drag in some of these phagocytic cells to essentially opsonize this red blood cell. And the end result is pretty much the same thing, right? We're going to destroy our own host cell that has this antigen bound, only it's a little bit different pathway. It's through C3b. Remember, that's particularly high yield. Remember, C3b associated with opsonization. And you can also remember that we talked about IgG is also associated with this pathway. And guess what's bound to the surface of these cells? IgG in most cases, right? IgG. And so IgG, like we said, is also very much associated with opsonization, and that's where this all comes together. C3b, opsonization, IgG, opsonization. Third thing on here is chemotaxis. Okay, so remember, again, going back to your complement cascade, C5a is going to be a very important chemotactic factor in conjunction with LTB4, interleukin 8, right? Those are really important neutrophil chemotactics, and those cytokines can essentially stimulate neutrophils to come to the site of wherever this antibody might be, right, with this complement, right? You might have chemokines getting released to these red blood cells. And these neutrophils, when they get to these red blood cells, they're just going to dump peroxidase and a lot of these really toxic chemicals on the red blood cells to destroy them. Now remember, we're targeting, in this situation, one red blood cell. When we talk about type 3 hypersensitivities, we're talking about like an entire region of the body or entire organ potentially that's going to get targeted. And so you can imagine that chemotaxis and complement-mediated C5a release is going to generally be much higher when you're targeting a whole organ, for example, like the kidney. In this situation, if we're just targeting red blood cells, you're not going to get as many neutrophils to the scene because these red blood cells are always moving around. So these neutrophils will play a little bit bigger role when we talk about type 3 hypersensitivities in terms of the damage that they can cause. And the last one on here is the natural killer cell. Now this ADCC, antibody-dependent cell-mediated cytotoxicity. And this is largely driven by natural killer cells. And what this essentially means is, the name kind of gives it away in a sense, antibody-dependent, right? We need this antibody here. This antibody will essentially bind to this receptor on the natural killer cell. So it's dependent on an antibody and it's cell-mediated cytotoxicity, meaning the natural killer cells are going to mediate the destruction of this cell. Kind of similar to what happens with the neutrophil, but not exactly the same because there's not chemokines necessarily that are stimulating this natural killer cell to come over here. This natural killer cell is binding to the IgG receptor here and then releasing perforins and granzymes to essentially destroy the red blood cell. Okay, so just remember, these are your 4 kind of major pathways, and a lot of this is really complement mediated. I mean, if you're just looking, just trying to remember this, you can really remember that this is a large portion of the cell destruction that's happening because we're binding to our own cells is mediated by complement. You just have to be familiar with your complement cascade. This all goes back to the complement video. We're just kind of adding a layer to that, and then also be familiar with antibody-dependent cell cytotoxicity that's largely driven by antibodies that are bound to cells, and then remember that it's the natural killer cells that are going to come and bind to those cells and then destroy them. The other thing that natural killer cells are very notorious for is binding to cells that don't have MHC1. Remember, all of our nucleated cells should have MHC1. So when cells are downregulating MHC1, that could indicate potentially that there's a cancerous process or something wrong with that cell, and natural killer cells step in and then destroy host tissue in situations where those MHC1 complexes are downregulated. So the 2 big things to remember, again, for natural killer cells, 2 big things to remember is that they're going to target cells through antibody-dependent cell cytotoxicity, and then also they're out there searching for MHC1. And if they find a cell that doesn't have it, then they're going to destroy it. Okay, so those are the big things, and let me clear this up here. Those are the big things for natural killer cells to remember if you had to remember anything. Okay, so let's run through this really quickly. So again, this is sometimes referred to as a cytotoxic process, right? A cytotoxic hypersensitivity. Why is it cytotoxic? Because we're destroying cells, right? Cytotoxic, cell toxic, we're destroying cells. And the way this happens, like we said, we're gonna have an antibody. That antibody is gonna bind to our own host cell surface through an antigen, okay? Or there'll be graft tissue, which we'll talk a lot more about in the transplant rejection video. Again, 4 processes. A lot of this, like we said, really just mediated by complement. So if you're familiar with your complement cascade, I think this will make a lot of sense. So C3b, C5a, ADCC, we all kind of talked about that. Now, you should also know kind of what pathology falls into, each category of hypersensitivity. So autoimmune hemolytic anemia, very classic for this type 2 hypersensitivity, where you have antibodies that are binding to your red blood cells and eventually causing complement-mediated lysis and ADCC of those cells. The same thing is true with your platelets. You can have immune thrombocytopenic purpura, right, ITP, acute hemolytic transfusion reactions. So this is very classic if you have a patient that receives blood from somebody else and they're not matched, right? If you have mismatched blood being donated, right, and then given to a patient, right? So this is going to be mismatched blood. Is very classic for this. Obviously, we do a type and screen whenever we donate blood. I mean, emergent situations, they'll sometimes use O negative, but in general, we're trying to match the blood so we don't run into the situation. Like I said, I'll talk about this one in more detail when we come to it. But remember, the concept is the host has antibodies to certain markers on red blood cells. Depending on what the person's blood group is, they could have antibodies to other types of red blood cells, right? And so when you give those red blood cells, those antibodies then, what do? They can bind to this donated red blood cell, right, that has these different markers on it, and then can target it for destruction, and you can end up with a transfusion reaction. The other thing on here is erythroblastosis fetalis, and this is sometimes referred to as the hemolytic disease of the newborn. Okay, so we'll talk about this probably in its own video, but just to give you a high-level overview, essentially what we're talking about here is, and let's clean this up a little bit. So essentially what we're talking about here is certain red blood cells in mom. So I'm just going to put mom here. Okay, so certain red blood cells in mom can have markers on it. Okay, so we'll call this an RH marker. Okay, so we'll say RH positive, and then we have fetus over here. So we have mom, and then we have fetus. Now, if mom's RH positive, generally she won't have antibodies against this factor, because if she did, she would then be destroying her own cells. Okay, so usually if mom's RH positive and baby's RH positive, everything's okay. But let's imagine that instead of mom being RH positive, if mom's RH negative, on the other hand, what that means is mom doesn't have this antigen on her red blood cells, but baby has it, right? And so what mom might do is mom might say, hey, mom's body might recognize this antigen as foreign, okay? Because mom doesn't have that on her cells, but baby does. And so what mom would do in this type of situation, potentially, is mom might start to generate antibodies against this RH factor. Now remember, in the placenta, we talked about this, there's only really one major antibody you need to remember that crosses the placenta, and that antibody is going to be IgG. And what are we talking about right now? What's the major antibody here? We already said IgG, right? If this is the first baby, right, this is fetus number 1 that's RH negative, it's going to take mom a little bit of time to go through class switching to generate IgG antibodies. Remember, her IgM antibodies aren't going to do a really good job of trying to get through the placenta because they're so big, right? They're pentameric, at least a lot of them are. Okay, so this first baby is not really going to get affected. But what's going to happen is mom's going to start to generate antibodies. There's going to start to be class switching against these antigens. They're going to get presented essentially to mom. Okay, and you're going to start to get T cell activation, memory response, all those things we talked about in the previous videos. And so mom, from this first fetus, will start to make antibodies. For baby number 2, though, okay, so baby number 2, let's say mom has a second baby. Okay, let's say this baby is RH negative. So if this baby is Rh negative, it's unlikely that mom would target this baby with antibodies, right? Because there's nothing to target. This antigen isn't there. There's nothing for the antibody to bind to. Mom's Rh negative, baby's Rh negative. So if fetus number 2 is Rh negative, we wouldn't have anything to worry about. However, if fetus number 2 is Rh positive, right, just like baby number 1, now we have that antigen on here again. And now mom's antibodies are ready to go. Mom already class switched. She already has a memory response. These IgG antibodies are going to go right through the placenta and right to fetus number 2 and start to bind to this antigen. And it's going to look just like what we saw here. This would be your Rh positive antigen, right? That's what's in yellow here. And then here's your IgG antibody. And we would go through all of the same process that we talked about right here. We'd have baby cells getting targeted and getting destroyed. And this is obviously a very serious situation, okay? And we won't go into any more detail than that for this video, but that's really the mechanism, the idea of what you want to have when you think about erythroblastosis fetalis. Now, there's other examples here that are more inflammatory in nature. When I say more inflammatory in nature, I'm talking about more involvement of kind of a general tissue, but we don't have complex formation. The thing that defines type 3 hypersensitivity is that we start to make these complexes with the antigen and antibody. In type 2 hypersensitivity, most of the stuff we're just targeting single cells. But here, if we're targeting kind of an overall structure, for example, in Goodpasture syndrome, we're going to target type 4 collagen in the lungs and the kidneys. Okay, and so because there's not complexes, though, it actually goes into this type 2 hypersensitivity category. Okay, so again, you want to categorize these diseases into these different hypersensitivities. The same thing is true with rheumatic fever. Hyperacute transplant rejection is actually quite similar to the hemolytic reaction. Remember, when you start to transplant tissue, everybody has different HLA markers. You have to match up your HLA phenotypes. If you have a different HLA phenotype, when I put a graft in another patient, right? So here's my host or my recipient, right? You can call it either one, my host or my recipient. And then you have your donor, right? You have your host and your donor, okay? And the donor is going to give the host something, right? They're going to give them some kind of transplant. Let's just say, the donor we're doing a renal transplant, right? So the donor is going to give their kidney to the host, okay? So now the host is going to have the donor kidney, okay? But remember, the host is going to have different HLA markers, right? So the host might have one HLA marker. Let's just call this person HLA-A just for simplicity's sake, and let's just say that this person is HLA-B, okay? So if they have different HLA markers, those markers on the cells, right, this HLA-B marker on this kidney tissue might be foreign to this host who only has HLA-A. And so for that reason, this host might already have some antibodies against HLA-B, right? They don't have an HLA-B in their tissue. This is foreign to them. And so they already have these antibodies. They can bind to this tissue and essentially mark it for destruction. And again, this can lead to complement activation. We can have thrombosis of these vessels because of the infiltration from all this tissue and the inflammatory response. And that can also be problematic. And we'll talk about that more, like I said, when we go through the transplant rejection. So in the first few examples, we're talking about cells that are essentially marked for destruction. But now you can imagine these antibodies, instead of necessarily marking things for destruction, antibodies can also act to bind to things. They can bind to receptors or they can block receptors. So if we're talking about something like myasthenia gravis, for example, with myasthenia, you can see these receptors, these IgG antibodies are essentially binding to the acetylcholine receptor here in the neuromuscular junction. So you can see here, these are all going to be your acetylcholine receptors. And here you have your acetylcholine, right? It's traversing the synaptic cleft, trying to make its way to the receptor. But guess what? All of these antibodies are blocking the receptor, which can eventually lead to that muscle fatigue that we talked about in the neurology section, where these patients will typically, especially with the cranial nerves, these patients will tend to have difficult time after repeated motor stimulation. In Graves' disease, this is another classic one where the antibodies not necessarily destroying or marking a tissue for destruction, but instead stimulating a receptor. So with myasthenia, we're blocking the receptor, so we can't stimulate it. Here, we're actually stimulating the receptor using antibodies. So you can see TSH can bind to some of the receptors in the thyroid follicle and cause thyroid hormone production. But we can also make antibodies that bind to the receptor as well and also stimulate the receptor to make thyroid hormone production. And if we make too much of this thyroid hormone production, we end up in a situation with hyperthyroidism. And that's essentially what Graves' disease is, right? Because we're overstimulating the TSH receptor. Just to be familiar with, again, you want to know you have to understand the mechanisms and where these mechanisms fall into these different hypersensitivities. And again, their relevancy. Finally, the last two things on here, we have our diagnostics. So the direct Coombs test. It's very confusing for a lot of different people. So let me just kind of try to explain this. Okay, so you have to understand for each of these tests. So let's just write direct here. So this is going to be the direct Coombs test. So you have to understand for each of these tests what's going on with your host, right? This is going to be your patient. And then what are you adding essentially? Okay, so what's the lab thing that you're adding? Okay, so here's the host and what are you adding? So in this situation, in the direct Coombs test, we're testing for the antibody bound to host cells. So we have a host, let's just say we have our red blood cell here. Let's use the example we talked about. We have some antigen bound to that red blood cell. Okay, and that antigen, these antigens that are on our red blood cell, we have antibodies that are binding to those antigens, right? This is what we just talked about, right? So we have these antibodies all here that are bound to the antigens. Now, this is what we're going to have from the host. What we're adding to the host sample is going to be antibodies to the antibody. So we're adding some kind of anti-antibody. Okay, kind of what we talked about before. And so what this looks like is, so when I add these two things together, these anti-antibodies are going to bind to the Fc portion of the antibodies that are bound to my red blood cells. Okay, and what happens is when I get a bunch of these added antibodies binding, it's going to cause this whole solution to agglutinate, because you can imagine there's going to be other red blood cells here. They're all going to agglutinate, and that's going to indicate a positive test. In other words, we're testing to see if the host has antibodies bound to the surface of the red blood cells. If the host didn't have antibodies bound to the surface of the red blood cells, these blue antibodies, these anti-antibodies, they'd have nothing to bind to, and so we wouldn't get agglutination. So agglutination is going to be a positive test, right? What does that mean? What does it mean that it's a positive test? It means that the host cells have antibodies bound to them, and the antibodies that we added bound to those antibodies. And where do they bind? To the Fc portion of the antibodies bound to the host cells via the anti-antibodies Fab portion. Okay, so I know it's a little confusing, but again, the important thing is in the details. That's what you have to pay attention to. What does the host have, right? What's in the host sample, and what are we adding? So the host, we're just going to add the host's serum. And the idea here is if the host has antibodies in their serum, we can add red blood cells, potentially with some antigen, to see if the host cells will bind to that antigen. Okay, so here's my red blood cell with the antigen. And again, it's not the host's red blood cell. We're adding some external red blood cell with the host's serum. And what happens if I put these together, right? If I put these together, these antibodies are going to bind to these antigens. And what would I expect? I would expect agglutination, right? If there were antibodies in my host serum, which again would be a positive test. And you can imagine the classic antigen that's going to be on red blood cells that we add for doing this agglutination, we might be testing to see if we have red blood cell transfusion compatibility, right? Because different hosts, right, different people will have different markers on their red blood cells, right? If you're type A or type AB, positive, negative, right? And so we might be testing to see if the person that we're going to give this blood to has antibodies to the donor. So we might be seeing if the person that's going to receive the blood, right, that being the host, has antibodies to the donor's red blood cells. That's the solution that we're essentially going to be adding to the host's serum. Okay, so that would be a red blood cell transfusion reaction we would be testing for. We can also do this for hemolytic disease of the newborn, or erythroblastosis fetalis, right? We can test mom serum, right? In this situation, this would be mom serum for the antibodies to the Rh factor. Okay, and we can add in red blood cells that are Rh positive, right? So we can use this test, the indirect Coombs test, for things like this specifically. And if you're getting questions on, well, what is this test looking for? Again, we're testing for if the antibody is present in the host serum. If it's present, we add something that we suspect has that antigen. If we get agglutination, we're confirming that the host has the antibodies in the serum. With the direct Coombs test, remember, it's a little bit different. We're looking to see if there's antibodies already bound to the surface of the host cells. So we have to use an antibody that binds to that Fc portion of whatever we think this pink antibody might be. So I know that's a little confusing, but again, understanding the details is critical to getting a lot of these questions right. So just kind of go through this a couple times if you're a little unsure. And a lot of this builds on the previous videos. So if it's a little confusing, go back, check out the previous videos, and I think it will probably make more sense. All right, so type 3 hypersensitivity. So how does this compare to what we just talked about with type 2 hypersensitivity? Remember, in type 2 hypersensitivity, we have antibodies that are binding to the antigens on the surface of cells primarily. When we're talking about type 3 hypersensitivity though, these antibodies are binding to these kind of free-floating antigens or soluble antigens in the bloodstream. So the key word here is soluble. So we have antibodies that are binding to these soluble antigens. In other words, they're kind of just free-floating, and you can see these antibodies binding to them. Now in a type 2 hypersensitivity, we talked about these antibodies binding to antigens that were on the surface of cells, and the cell that we use as an example was a red blood cell. So instead of this antigen kind of free-floating, that antigen would have been on the surface of this red blood cell, and then our antibody would have bound to that specifically. Okay, and then that would have marked this red blood cell essentially for destruction. And that was what we talked about with the type 2 hypersensitivity. And again, type 3, these antigens are kind of free floating in the blood. And so, what's kind of the repercussions of that? Well, there's a couple things. You can imagine that if you have a bunch of these antibodies and antigens kind of getting stuck together, so to speak, and kind of forming that snowball effect where, that it's just going to get bigger and bigger and bigger and then get deposited into tissues. What happens here is you kind of see this arrow pointing down as this gets deposited into the endothelium here. As more and more of these antigen-antibody complexes get together, you're going to start to get complement activation on all of these FC portions of these antibodies. So complement is going to start to get activated. And we just kind of talked about that in the last video. What are the repercussions of that? Well, if it was a single cell, you'll see a lot of the membrane attack complex being released. But one thing you'll see, especially in the bloodstream here, when you have these immune complexes, is you'll get a lot of the C3, C4, C5a getting released. And when you think about type 3 hypersensitivity, think of this as being even a stronger level of complement response than you typically see in a type 2 hypersensitivity. And you might be saying, well, why is that? The reason is because you have all of these antigen antibody complexes together and all of these FC portions getting complement activation in this one location. So what happens with that? Well, remember, C3a, C4a, and C5a are all going to work to increase vascular permeability. That can lead to edema. So this is something that we've already kind of touched on, but the even more important thing is, remember, C5a specifically, we just talked about this in the last video, is responsible for neutrophil chemotaxis. That's particularly high yield, along with LTB4 and interleukin 8. So neutrophil chemotaxis to this site, you're going to get a whole bunch of neutrophils, right, from all of this complement activation. You're going to have all of this C5a. So you can see all of this kind of C5a, we'll just call it here, kind of getting released down into the bloodstream. And that's a chemokine. It's attracting all of these neutrophils to the scene, right? So these neutrophils are coming to the scene. And when these neutrophils get here, what are they going to do? They're going to dump tons of myeloperoxidase and peroxidase and just damage all of this tissue where these immune complexes are getting deposited. And this is on a pretty large scale in a lot of situations. So that you're going to have lysosomal destruction of that tissue. So this is essentially explaining the inflammation you get, right? When you talk about something like vasculitis, right? If I say, okay, this patient has, vasculitis secondary to type 3 hypersensitivity. What am I saying? Well, itis, right? We're just saying inflammation of the vessels. Where's that inflammation coming from? The neutrophils. Where's the neutrophils coming from? C5a. Where's the C5a coming from? Complement. And where's that complement binding to? They're binding to all of these antigen immune complexes. If you can kind of go through this in your mind, it's hard to get questions wrong because you understand the process, right? If you understand the process, you know how to play the rules of the game. You just have to apply that knowledge, just to apply the foundations. And that's essentially what we're talking about. So that's what vasculitis essentially comes from, right? So you have inflammation in the blood vessels secondary to this immune complex formation, right? And so the classic example of that would be polyarteritis nodosa, okay? And this is very classic for patients that have had hepatitis B infection in particular, and that's particularly high yield. And we'll talk about that more in the room section. Another classic one is post-strep glomerulonephritis, which is actually the most common cause of nephritis syndrome in children, okay? So it tends to get asked about very frequently. These patients will have all of this happening essentially in the kidney, and so they'll present with hematuria, edema, high blood pressure at some time after a strep infection. Usually 2 to 4 weeks is the normal range, right? 2 to 4 weeks after some kind of strep infection is very classic for causing this. And the classic strep infection that you should be familiar with is strep pyogenes, right? That's going to be very, very high yield to remember. And we'll talk about this more in the renal section. But again, it's applying that knowledge to understand the pathophysiology. That's where a lot of the questions come in. Lupus, it's the same thing. Again, we're targeting the kidneys in this situation. That's our tissue, IgA nephropathy, all of these being kind of that same category. And then hypersensitivity pneumonitis is also in here. Okay. And again, the point of this video though is not so much to go through each of these diseases, but more so to understand this mechanism. Again, antigens are binding to immunoglobulins, soluble antigens, floating around in the blood, not on any tissue at this point. Then they're forming these immune complexes like we see here. Those immune complexes are then getting deposited into tissues. If it deposits in a blood vessel, I get a vasculitis. If it deposits in a joint, I get an arthritis, right? If it deposits in a kidney, I get a nephritis. Now, the thing that I said earlier is the complement activation is quite extreme, especially compared to the type 2 hypersensitivity. And the thing that you want to remember about that is the neutrophils are really mediating a lot of the damage here, okay? Because there's so much immune complex formation, there's so many FC portions kind of localized in that one location, you're getting a lot of neutrophils to one spot, and they're all kind of just dumping their myeloperoxidase, peroxidase, all these toxic substances onto the host tissue. Okay, so we kind of already touched on this, correlating with the tissue involved. Now, one image that I think is relatively high yield is just understanding, when you get a patient that has vasculitis, as this is kind of the classic type 3 hypersensitivity along with some of these nephritic syndromes, it's important to understand kind of what you're looking at. Okay, so when you're looking at this slide here, I can see that this is a blood vessel, right? So I can see that I have a blood vessel here. I can see it's got kind of a muscular outer wall here, right? So probably arterial. And then you can see all of these red blood cells in the middle here. So that tells me this is some vessel. And if we go zoom in a little bit, we can see kind of the outside of that vessel. You can see all of your red blood cells are here, right? You have all of your red blood cells, Okay, and then you can see there's also a bunch of neutrophils in here. So we have a lot of inflammatory cells that look like they're inside this vessel. And then you can kind of see that here too, right? In this vessel, here's your muscular lumen, right? You see your red blood cells here, and you can see that there's a huge inflammatory infiltrate here. And so when you see something kind of similar to this, where you see a lot of, and the easiest thing to do is just to look for inflammatory cells. The inflammatory cells everywhere is going to be significant in patients that have some type of inflammation ongoing. A lot of times you'll see the inflammation in vasculitis described when they're looking at the blood vessels as a fibrinoid necrosis. This vasculitis in particular, the other thing to know is, again, because it's mediated primarily by leukocytes, right? It's mediated by white blood cells like neutrophils. Sometimes this vasculitis in particular, when we're talking about this, is called a leukocytoclastic vasculitis. And so what they're essentially saying is it's a vasculitis that's primarily mediated by leukocytes, right? And so that's the concept. So that's when you see leukocytoclastic vasculitis, fibrinoid necrosis. These are all kind of big words, kind of scary words if you don't know what they mean, but they're really just talking about a vasculitis induced by the leukocytes because of the complement activation, right? And then also you have a huge inflammatory infiltrate. You have necrosis of this tissue because you're dumping all this toxic substance onto the lumen, essentially, right? Or the blood vessel wall, and that's causing you to have some necrosis. So serum sickness is also very classically talked about with type 3 hypersensitivity. Now, let me just kind of clean this up a little bit so I can tell you a little bit about this. Okay, so when we're talking about serum sickness, the classic kind of way this is going to get asked about is usually with antitoxin or antivenom. So let's just say that we have a patient that gets bitten by, and this is supposed to be a rattlesnake, okay? So this rattlesnake is essentially going to, inject some type of antigen, right, into this patient that's essentially going to cause an inflammatory response. Okay, and we want to give this patient an antitoxin to that antigen, right? So what this patient does is they come to the emergency room and they have symptoms, etc., and then we give them the antitoxin to that rattlesnake, for example. Okay, so we give them the antitoxin, and this antitoxin is essentially going to be binding up to these antigens, right? And in some way, depending on what we're talking about specifically, if it's rattlesnake or tetanus, it's essentially going to eliminate that antigen from causing disease. And it could do this in a variety of ways. Again, this is gross oversimplification. But the concept is we give them an antitoxin. Now, the patient may, in some situations, create antibodies to the antitoxin. So the patient might say, look, this antitoxin is foreign to me. I don't recognize this antitoxin. So the body might start to make antibodies, right? So the plasma cells eventually will get wind of this, and they'll start pumping out antibodies to the antitoxin. So these antibodies will try to bind to the Fc portion of the antitoxin. So again, this is where you have to kind of be sharp on the name here. We're making antitoxin antibodies, essentially, right? For the plasma cells to start pumping out IgG antibodies, for example, to the antitoxin, we have to go through class switching, right? There's a lot of steps in the pathway, right? The antigen presenting cell goes to a T cell binds CD40 ligand, class switching, etc. All the things that we talked about already. So this process takes some time. Now we have a whole bunch of these antibodies around to bind up these antitoxins. And so what does that do? Well, now you have, if you can imagine this, you have an antitoxin that's bound to the antigen, and you also have the antitoxin antibody all bound in one structure. And so, of course, these are going to start to kind of congregate, and you get what? You get immune complex formation, which is the classic thing that we're talking about with type 3 hypersensitivity. And this can happen throughout the body. Okay, so again, just reading through this, we have antitoxin, antivenom antibodies, and the other ones that are very classic for this are the monoclonal antibodies. These are going to be very classically recognized as foreign. Remember, these are going to end in MOB, right? Those are the monoclonal antibodies. A board question in some situation can ask you about a patient that recently received one of these and now has immune complex formation, or now has vasculitis, or arthritis, or glomerulonephritis potentially from exposure to either monoclonal antibodies or antitoxin antivenom. Now, what can you test for? And this goes for all of type 3 hypersensitivity. What you can test for is you can test for C3, C4 levels. And you might be saying, well, why is that? The whole crux behind this type 3 hypersensitivity is that you have widespread, massive amounts of complement activation. And if you have massive complement activation, significantly higher than a type 2 hypersensitivity, you would expect your complement levels to be low in the serum because you're using up a lot of that complement. Now, of course, you might be saying, well, what am I going to look for on pathology, for example. If I have a patient with serum sickness, well, we already talked about it. You're going to look for vasculitis. You're going to look for arthritis, glomerulonephritis. You're going to look for tissues generally that have immune complex formation that are getting damaged, some kind of inflammation. And a lot of times this could be systemic because these antibodies are traveling everywhere in the bloodstream, depositing everywhere. The thing that you have to be careful about is serum sickness-like reaction, because occasionally this gets distinguished from serum sickness, and this is not the same thing. The big thing to remember is that serum sickness-like reaction is not considered to be a type 3 hypersensitivity. Okay, so it is not in this category. Serum sickness is considered to be a type 3 hypersensitivity. Serum sickness-like reaction is not. And there is no immune complex formation, which is essentially why it's not considered to be type 3 hypersensitivity. And the idea here is that this presents similarly to serum sickness, but because there's no immune complex formation, generally the symptoms are much milder and the complement levels are normal because complement is not causing the symptoms per se. This just has a similar presentation. So it's a different mechanism, different pathophysiology. It just presents similarly, less severe, normal complement. Classically, penicillins and cephalosporins are kind of notorious for kind of getting in this category. Now, of course, you can take penicillin and have a type 2 hypersensitivity, right? We kind of already touched on that. This isn't saying that penicillin only causes serum sickness-like reactions. This is just a very classic presentation. So if you start to get a patient that has a little bit of arthropathy, maybe they have some hematuria, but they have normal complement levels, no immune complex formation, and they're bringing up penicillin or cephalosporins that the patient was recently started on, it would be a tougher question, but you would probably want to start to think about serum sickness-like reaction, especially if they did some biopsy and there wasn't really an inflammatory infiltrate, right? All right, the last one on here is going to be the Arthus reaction, and this is probably the least high yield of the ones above, but it is something that comes up occasionally, very classic as a complication of the Tdap vaccine. And this is essentially talking about a more local immune complex formation. So remember, with serum sickness, this is everywhere. This is in the blood. We gave that antitoxin, right, systemically into the bloodstream. Whereas with an Arthus reaction, you're injecting usually in one area, and so you have a local reaction just in that area where you have immune complex formation. And what happens is, initially, again, just like with the antitoxin, the first time you give the vaccine, the body might make some antibodies to it. And with Tdap, right, or DTaP, starting in the younger population, what happens is over time, you're constantly exposed to that vaccine because you need a lot of boosters, right? And so over time, you make antibodies, right, to those Tdap antigens. And so eventually, as you get the vaccine, right, what's going to happen is you get this kind of local reaction. You might get local, swelling. You might have a little bit of complement activation in that one area, a little bit of inflammation in that one area, but overall, significantly less severe than what we're talking about with something like serum sickness. And again, this is going to be very classic as a complication of a vaccine that requires a lot of boosters. Tdap tends to be the classic. All right, congratulations. We have made it to the type 4 hypersensitivity. If you've been following this video series, so far, this is actually probably going to be one of the easiest hypersensitivities to understand because we've talked about this mechanism so many times that at this point, it should be pretty much review in terms of T cell activation component. And again, the thing is that I'm kind of referring to here is, when we talked about type 1 hypersensitivity, we were talking about IgE antibodies. When we talked about type 2, we were talking about, IgG, maybe IgM, binding to the surface of cells. Type 3, we're talking about immune complex formation, IgG being very classic. But you can see in all these situations, we're talking about an antibody. We're talking about some kind of humoral response, right? But in type 4, it's kind of in its own world over here in the sense that this is primarily going to be T cell mediated, and it's going to be more, like we said, cell mediated response because we have T cells involved. So it's a little bit different in that sense. It's not necessarily humoral. There's no antibody that's classically going to be kind of potentiating this pathway. Okay, just to clean things up here a little bit, let's just go through an example of this. So allergic contact dermatitis is kind of like the poster child for this. And when we're talking about this, there's a few different causes, right? Poison ivy's one, latex, nickel. Let's just go with poison ivy here and we can kind of go through a demonstration. So, poison ivy, our patient, this is the surface of their skin, right? And they're having some exposure to poison ivy. Maybe they were outdoor camping, which would be very classic. Whatever the case may be, this patient was exposed to poison ivy. Okay, so this patient was exposed, and this chemical that's released here, this is urushiol. Okay, and this chemical is very classic for causing some of these symptoms. Now, urushiol is actually a hapten. It is referred to as a hapten, and essentially what that means is it can bind to proteins and then have that protein with the hapten presented to these antigen presenting cells that we see here. And so, if we're talking about the skin, what kind of antigen presenting cell we're going to have here? Well, primarily probably Langerhans cells. And those cells will find these antigens and bind to them, right? So they'll bind to their corresponding receptor, binding to the epitope. And of course, this is the same thing that we've been talking about, from day one, watching these videos, right? So the antigen presenting cell is going to present that antigen on MHC2 to a CD4 positive T cell, right? And then that CD4 positive T cell with the matching T cell receptor, CD4 positive co-receptor, will bind to that antigen. It will get activated, right? And then this antigen presenting cell will activate it using interleukin 12, right? Interleukin 12 will be used to activate the CD4 positive T cell. And then this CD4 positive T cell will then form a T helper 1 cell, again, because it was stimulated with interleukin 12. And then that T helper 1 T cell will then go on to release interferon gamma to activate antigen presenting cells, particularly macrophages, to release chemicals at the site of the urushiol. That's where that inflammation is going to be. So again, same concept we talked about. It's literally just the T helper 1 response that I'm referring to here. The important point, though, is you have to know, is this the first exposure or re-exposure? This is something that we keep kind of going back to. On initial exposure to this antigen hapten complex, the antigen presenting cell, like we said, will present to the CD4 positive T cell, binding via MHC2. Interleukin 12 stimulates differentiation to a T helper 1 cell, and then that T helper 1 cell will release interferon gamma. That interferon gamma will essentially stimulate macrophages. However, on that initial exposure, this isn't going to tend to be as dramatic as subsequent exposures, right? The memory response is going to be much greater. So if I'm exposed to this again down the road, I'm going to have preformed T cells that are ready to go in this tissue the next time I get exposed to urushiol. And in that situation, I'm going to have a lot more interferon gamma released from those T helper 1 cells, meaning there's going to be a lot more macrophage activation, meaning that this inflammation is going to be a lot worse, right? That's the idea. I'm going to have more interferon gamma release because I have more preformed T cells, because I generated a memory response, right? Because I generated a memory response. That's the key. So subsequent exposures will be worse. It's kind of like what we talked about with the type 1 hypersensitivity, different pathway though, right? And so again, we'll generate an inflammatory response. And the other thing is, remember, these antigen presenting cells, right? So let's just kind of clear some of this up. These antigen presenting cells here that are binding to these proteins, these haptens, if they're binding them up or if they're phagocytosing something to present them, then they're going to be on MHC2, right? Remember that. So if you're phagocytosing something, if it's an extracellular antigen, it's going to be on MHC2. However, remember that all of our nucleated cells have MHC1, including the antigen presenting cell. Now, the antigen presenting cell will usually only display antigens on MHC1 if it's infected with them. Like if there was a virus, for example, a virus could infect an antigen presenting cell, cause it to then be presented on MHC1. And remember, if you present on MHC1, the cytotoxic CD8 positive T cell can then get activated and destroy it. In this situation, urushiol isn't necessarily infecting the antigen presenting cell. So pretty much the antigen presenting cells will just present on MHC2. However, there is urushiol that's going to be in close contact with some of this epithelial tissue. These epithelial cells can potentially present on MHC1. That MHC1 presentation would cause activation of CD8 positive T cells, eventually cytotoxic killer CD8 positive T cells that would then release perforins, granzymes to cause inflammation to the tissue here. In fact, a lot of the inflammation and tissue damage you see here on subsequent exposures is because of the CD8 positive T cells that are ready to go from this memory response to wreak havoc and damage at these sites that are exposed to the urushiol. Okay, so again, key points here. Number one, it's a T cell response. Memory response is a much higher on subsequent exposures, similar to what we talked about with type 1 hypersensitivity, even though this is a different mechanism, right? It has to do not necessarily with the class switching of antibodies. It has more to do with a memory response of preformed T cells that are ready to go in response to these antigens, generating larger quantities of interferon gamma, more macrophage activation, more cytotoxic killer T cells that are ready to go. And again, also remember, all of this interferon gamma is going to cause your acute inflammatory response. The key 3 cytokines to remember for that were TNF-alpha, interleukin 1, interleukin 6, right? So that's where you can get fever potentially from this. You can get some edema in this area, right, as you get fluid leaving this area because of this inflammatory cascade. And remember, kind of 2 divisions here, right? You have your T helper 1 response, you have your cytotoxic CD8 positive T cells, all of this being cell mediated. And that's why before I kind of said that the T helper 1 response is in some ways part of that cell mediated cascade. Okay, and the only thing I think I skipped on here was this interleukin-2. Just remember, these T cells that when they get activated, interleukin-2, remember what it's responsible for. It's basically responsible for T cell growth. It can be autocrine, paracrine, endocrine, right? It can stimulate T cells anywhere. Even the T cell that releases interleukin-2 can then get stimulated by the interleukin-2 it released. With that being said, CD8 positive cytotoxicity is a big factor in a lot of these situations. Like I just said here, right? CD8 positive T cells can wreak a lot of havoc and cause a lot of damage simply from releasing perforins and granzymes on subsequent exposures. In situations like MS, we're targeting oligodendrocytes, right? Inflammatory bowel disease, type 1 diabetes, we're targeting the pancreatic cells. Hashimoto's thyroiditis. Remember, Graves' disease, if you're comparing the two, Hashimoto's being hypothyroidism, Graves, you're thinking hyperthyroidism. Graves' disease is a completely different mechanism, right? We're not using CD8 positive T cells to destroy thyroid tissue in Graves' disease. In Graves' disease, we're essentially going to be taking antibodies to bind to the TSH receptor to stimulate it to cause more thyroid hormone to be released. So again, that you have to understand the mechanisms here. If you understand the mechanisms and how all of this works, you're going to get a lot more questions right than if you're just trying to memorize where things fall, right? You have to kind of understand what's happening. In this situation, we're literally just destroying thyroid tissue as opposed to stimulating a receptor that causes more thyroid hormone to potentially be released. And again, CD8 positive T cells primarily will be binding to MHC1. Remember, almost all of our nucleated cells are going to be displaying this. If T cells recognize something on MHC1 that's foreign, they'll destroy it, right? If it's on oligodendrocytes, if oligodendrocytes are foreign to our T cells, if our self-tolerance isn't preserved, so to speak, through those initial steps in negative selection, right? If that wasn't effective, or if we have a poor T regulator response, we might be targeting our own tissues. Okay, and these are all things that we've talked about already. And how are we doing that? We're doing that by having CD8 positive T cells bind MHC1 on our nucleated cells, particularly in the case of MS, oligodendrocytes, pancreatic tissue, thyroid, whatever it may be. I put a little bit of skin differential on here. The only thing, I really want you to take away from this is going back, just because we're talking about the skin. I don't want to make this like a derm lecture or anything, but just know allergic contact dermatitis. We talked about the big three on here. Dress syndrome is drug rash and eosinophilia with systemic symptoms syndrome. I know that's a mouthful. Really, the big thing for this is a patient that was just started on allopurinol. That's like the classic drug. Doesn't have to be allopurinol, and allopurinol can be seen in hypersensitivity reactions, etc. But the point is, with DRESS syndrome, when you're comparing it to some of these other pathologies, DRESS syndrome is very classic for happening, 1 to 7, 8 weeks after you start the drug. So it's going to be sometime after you start the drug, a few weeks after, and the patients will have eosinophilia, just like the name says, right? You have the E for eosinophilia. They'll also have variations in the platelets and the lymphocytes, right? I don't want to go into all the details on that, but just something to be familiar with. We're talking about the different medications here. So allopurinol for DRESS syndrome. And then when you're thinking about SJS and TEN, which you can also see allopurinol with, but the big two drugs I want you to remember are going to be lamotrigine for SJS and TEN. And by the way, this is Stevens-Johnson syndrome and toxic epidermal necrolysis. And you can check out our derm videos for, a really good explanation on this, but I don't want to get too off track. But lamotrigine is one big one. And then the other one is trimethoprim sulfamethoxazole. So these two are going to be very classic for causing this syndrome in particular, or at least putting patients at some degree of risk. I also put phenytoin and carbamazepine on here just because, like lamotrigine, it's kind of like that whole anti-epileptic category. It can get plugged into that SJS-TEN profile. So just something to keep in mind. But particularly if you see a question about lamotrigine or trimethoprim or sulfamethoxazole, just keep that on your radar. Okay, the last thing I want to talk about on here is going to be the tuberculin skin test and the Canada skin test. And so just remember what we're talking about here is we're talking about injecting some antigen, right? So we're injecting some antigen. And if I've had exposure to this antigen before in the past, then I'm going to generate a response, right? I'm going to have antigen presenting cells, same pathway we talked about, activating our T cells. If I've been exposed to this before, I'm going to have pre-formed T cells that are pretty much ready to go, okay? In fact, there could be T cells that recognize this antigen directly in certain situations, but a lot of times there'll be an antigen presenting cell initially kind of surveying this area, presents it to a T cell, and these T cells are ready to go. We're going to have a memory response. So we're able to generate, a relatively fast response within, 48 hours or so, where these T cells can then cause, right, cytotoxic T cells, CD4 positive T cells with activating macrophages can cause there to be some induration that forms here. So we're just going to call this an induration. And this basically shows that we had been exposed to whatever antigen we injected into this patient, right? It shows that we've had a previous exposure. We were previously exposed to that antigen. And this, again, is very gross oversimplification. I think we went through the pathway a little bit more when we talked about the Canada skin test, but it's the same pathway that we've been going over this whole time with T cell activation, T helper 1 response. Okay, the point is it's a cell-mediated pathway, okay, and you need T cells. You need T cells for you to generate this induration. You can imagine if I took out these T cells, I wouldn't get the induration here. Okay, that's the point. All right, so you need T cells. So let's just go through this. So the first thing, I'm gonna start here with the Canada skin test. If I gave a patient a Canada skin test, what would I expect to happen? So let's just say that here's a healthy patient, okay? Here's a healthy patient. We'll just draw a smiley face here. So this patient's healthy. This patient, if I did the Canada skin test on them, okay, I'm just going to put C test here for Canada skin test. If I did the Canada test, what would I expect to happen in a healthy patient? Would you expect to get an induration of some size, right? The answer to that is yes. You would expect there to be an induration because the patient should have been exposed to Canada. That's number one. They should have been exposed. You might be saying, well, how do I know this patient was exposed to Canada? Well, almost everybody is exposed to Canada at some point, right? It's a superficial skin infection. We just don't see Candidal infections because our body's able to fight it off. Okay, so but most people have been exposed to Canada. And so in a healthy patient, you would expect there to be an induration. Now, what about a patient, on the other hand, that's not healthy? Okay, so maybe a patient specifically, let's say this patient has SCID. Okay, so this patient has very low levels, if any, T cells, or maybe it's an AIDS patient, right? So this patient, we're gonna put no smiley face right now. So this patient is not happy, right? And so if I did the Canada skin test on this patient, would I expect to get an induration? And the answer to that is no. You wouldn't, because you don't have functioning T cells. If you don't have functioning T cells, because you can't go through a T helper 1 response, you can't have CD8 positive T cells attacking that area to cause there to be some inflammation to get the induration. Okay, so that's the point. Let's add a layer to that. Now let's talk about the tuberculin skin test. So now if I did a tuberculin skin test on a healthy patient who does not have TB, okay, would I expect an induration? And the answer to this is no, right? You wouldn't expect an induration if my patient was healthy and my patient did not have TB. Now let's say that I had a patient that is not healthy, right? And this patient also does not have TB. So this patient's not healthy, but they don't have TB right now. Okay, now let's say in our patient that's not healthy, this patient has SCID, for example, right? But this patient also does not have TB. Let's say I do the tuberculin skin test in this patient. Would I expect this patient to have an induration? And the answer is no, right? It's for the same reasons as the Canada skin test. It doesn't matter what T cell tests I do. In any case, this patient will not have an induration because they don't have T cells. Okay, not because they don't have TB, but because they don't have T cell. Okay, now what if these patients actually had TB? Okay, so let's do T test and then we'll put yes, TB. What if we did the T test and my healthy patient actually had TB? What would happen? So try and think about that. So if you had a healthy patient that has TB, what should happen on this test? Well, the T cells are working, right? And this patient has been exposed to TB. And when I put yes TB, I'm saying the patient's been exposed to TB at some point, right? They're previously exposed. That could mean that they have a current infection, they've been previously infected, right? Or maybe they even got a vaccine, like a BCG vaccine in the past. So they've had this antigen exposure in the past, right? So in this situation, if this patient had been exposed in the past, what would happen if I did the tuberculin skin test? Would I expect an induration? And the answer is yes, you would, right? Because you've been exposed to the antigen in the past and you have T cells here that are essentially functioning, right? So in this situation, we would expect there to be some response in my healthy patient, even though this patient's healthy in the sense that they have T cells, they are infected with TB or had previously been exposed, right? It could be either one, but they would generate an induration in that situation. Now, what about my not healthy patient? So again, we do the T test and we're saying, yes, this person has been exposed to TB. It could be an active infection, could be a previous exposure. Would I expect this patient to have a sizable positive test, right? A positive induration? And the answer is no, right? It doesn't matter what this patient actually has, what exposure they have. And why does it not matter? Because they don't have T cells. If you don't have T cells, no matter what, you can't generate the induration, right? If you have SCID, if you have AIDS, you're gonna have a problem in these situations, okay? So that's why they have to sometimes change the parameters of what is a positive test in patients that are immunocompromised. In a healthy patient, we would expect whatever this patient has in terms of exposure should be semi-accurate. And so what you can do in these patients, right? If you're not sure what the patient's T cells are like, you don't know if there's any anergy, right? In this patient, you can do a Candida skin test and a tuberculin skin test. So the Candida skin test, right, will just tell you if this patient has functioning T cells. You are expecting an induration, right? Are the T cells functioning? That's the question that the Candida skin test is going to answer, because everyone, more or less, should have been exposed to Candida. The tuberculin skin test, on the other hand, is going to answer, does this patient actually have TB? Okay, but you have to look at these together, right? So if you have a negative TB test, but you also have a negative candidal antigen test, well, that's not very helpful. That tells you that this patient might just be immunocompromised. That doesn't tell us if this patient has TB or not, right? It just tells us that this patient is probably immunocompromised. And so you're essentially using the Candida skin test as a control, okay? So this is where a lot of these questions come in, where you have to understand what's going on. You can't just sit back and memorize all this stuff. It would be pretty difficult. If you understand the principle behind each of these tests, the point is, if you've previously been exposed to an antigen, you generate an induration here. The key of that is that you need to know that you need T cells to generate that response. So you have to weigh in, has this patient been exposed, and do they have functioning T cells? And all of that has implications into your results. All right, so we just included this table here to recap some of the information. There's a ton of information on hypersensitivities, but again, we'll just go through the big stuff here. Remember, type 1 hypersensitivity, the classic term we use to describe this is immediate, because we have the preformed IgE antibodies on the mast cells and on the basophils. Remember, you have to have a second exposure, though, to get to that point, because we had to class switch to get those antibodies onto the mast cells and the basophils. The early phase is the phase that's classically asked about. Probably the most important thing to remember here is that we have mast cells and basophils along with preformed IgE that will cross-link when antigens bind, degranulation, histamine release. Remember, tryptase also, you can measure the serum for that. And then the late phase, remember eosinophils, but not quite as high yield. Urticaria, very classic initial symptom. What are we worried about? Anaphylaxis. If we're testing for it, we can test tryptase, which also gets released in the granules. We talked about that. You can do skin testing to look to see what exposure potentially this patient has had before. We talked about the key components here, and then some of the key examples: food allergies, insect stings, even certain medications being very classic for that. Remember that type 2 hypersensitivity, we kind of broke it down in a few different categories. Really, cytotoxic and inflammatory are similar. Inflammatory I just put on here because you have certain tissues that will have effects as opposed to just like one cell. The key between type 2 inflammatory and type 3 hypersensitivities is that type 3 involves immune complex formation, whereas type 2 does not. Okay, so that's particularly high yield. Type 2 cytotoxic, we're talking about cell destruction, tissue destruction, and then we can bind to receptors, essentially block receptors or stimulate receptors. Okay, and so we kind of talked about all that here. The complement cascade, intricately involved with the effects that we're going to see when antibodies bind to host surface cells via some antigen. And remember also, you have natural killer cells involved with antibody-dependent cell cytotoxicity. Autoimmune hemolytic anemia was very classic. We talked about the direct Coombs test to look for antibodies actually on the cell, and then the indirect Coombs test to look for antibodies in the serum. Okay, and you can also just simply measure a serum antibody. And then here's your classic examples. Talked about all of this in pretty great detail in the video already, so I won't go into too much detail here. Type 3, again, remember the key thing here, immune complex formation. Okay, immune complexes that are getting deposited kind of systemically. And the big thing is you're going to have much more significant amount of complement release on average here when you're talking about type 3 hypersensitivities. Vasculitis, arthritis, glomerulonephritis are very classic. You can measure the complement levels because of that extreme amount of complement activation. Finally, we talked about the type 4, very classically called the delayed or cell-mediated. Remember, these are all humoral. Type 4 are primarily going to be talking about T cells that are causing most of the havoc here. And the big one is the CD8 positive T cells activated via MHC1, but we can also see a T helper 1 response, largely driven by interleukin 12, interferon gamma. Okay, we talked about the tuberculin skin test, Candida skin test being more so used as a control to see if there's actual T cell function, as most people are exposed to Candida, tuberculin, then testing for tuberculosis, right? And then we talked about some of these different cell lines involved and some classic examples here. So a lot of information in this video. Hopefully you found some of this helpful, and I think the table does a pretty good job of just summing up the big key points. Take 15 seconds to pause the video, read the question, and then we will go through the answer. All right, so we have a 44-year-old African-American female with a past medical history of childhood asthma who's presenting to the emergency department with worsening dyspnea over the past 4 days. She states that she was initially treated for a presumed asthma exacerbation with an oral steroid medication. She also reports difficulty sleeping at night due to night sweats and worsening anxiety. Okay, she has approximately 9.1 kilograms or 20 pounds of unintentional weight loss. So now the night sweats and the unintentional weight loss, the first thing that you start to think about when you see these signs is you usually start to think about some form of malignancy. Typically, at least that's what I'm thinking about. This is happening over the past month. Additionally, she reports cramping, nonspecific abdominal and diffuse joint pain that started insidiously months earlier. Chest CT imaging reveals a large left lower lobe mass. Okay, so now I'm definitely thinking potentially lung cancer. We'll have to go back. I didn't mention any history of like breast cancer that can metastasize to the lungs. But yeah, large left lower lobe mass and significant hilar lymphadenopathy. Subsequent biopsy of a hilar lymph node is conducted and shown below. Bronchoscopy revealed granulomatous inflammation without evidence of malignancy or infectious etiology. Okay. A regimen of high-dose prednisone is initiated, and here is the biopsy of that hilar lymph node. Okay, so a couple things. So initially, again, even though this isn't a question on malignancy, I mean, they clearly state, right, the bronchoscopy that they did here, right, to look at that mass that was in the lung, there was not any evidence of malignancy or infectious etiology. Now, again, there are certain features here, though, that initially kind of called our attention to that. So it's important to kind of take that away from this question number one, is when you see unintentional weight loss, when you see night sweats, those are symptoms typically where initially I'm thinking, right, this could be lung cancer, right? Because she has this dyspnea, right, in a 44-year-old female. If she had a history of breast cancer and she had radiation in the past, that would put her at higher risk of lung cancer. So those were kind of the thoughts that were going through my head. Now, the fact that we know now that there is no evidence of malignancy here, what's going on with this patient? When you look at the question, there was one line here that kind of gave things away a little bit. There was significant hilar lymphadenopathy. When you see hilar lymphadenopathy in general, especially for a step 1 or complex level 1 exam, the first thing that I want you to just kind of think about, obviously lung cancer, is definitely something we're concerned about in this patient. But usually when they use this kind of terminology, they're usually talking about sarcoidosis. Typically, in general, sarcoidosis tends to affect African American females. And this is usually kind of like the classic way this is asked about. It doesn't have to be, but it's the classic patient that you're going to see this in. Usually middle-aged patients also. Okay, so this is very classic for sarcoidosis. And the other thing, besides the significant hilar lymphadenopathy that I'm looking at, is this lymph node biopsy. Okay, so this lymph node biopsy, the hilar lymph node, is showing something that's very classic here, and that's going to be these non-caseating granulomas. Okay, non-caseating granulomas are also very classic. And what we're basically looking at here in simple terms, you don't have to be a pathologist here, but basically we have this dense inflammatory infiltrate here. And we'll kind of talk about that in a second. A lot of these epithelioid cells that are going to be releasing things like 1-alpha hydroxylase, for example, right? They're going to be stimulating the conversion of vitamin D to its active form, causing hypercalcemia in sarcoidosis. So that's one thing that's going on. You're going to see these kind of multinucleated giant cells. And it's kind of hard to see. We're kind of in a low mag view here. But, if you had a higher magnification view, you'd see these cells that have kind of multiple nuclei that basically represent these multinucleated giant cells. Okay, and again, remember in non-caseating granulomas, right? When we're talking about non-caseating granulomas, like we see in sarcoidosis, right? Like we see in beryllium exposure or leprosy, for example, in these situations, right, you're going to expect there to be no necrosis, right? There's not going to be necrosis in the center of this granuloma. Now, this is juxtaposed to a caseating granuloma like you would see in tuberculosis, where you would expect to see necrosis in the center. Okay, and again, this is kind of a classic image, so I would be familiar with the appearance of granulomas on histology. But again, you have multiple clues here to tell you this is sarcoidosis. Now, the key here is to figure out what type of hypersensitivity reaction is related to sarcoidosis. So again, the first step, right, we had to identify that this is sarcoidosis. And again, we have some key clues here, right? We have the significant hilar lymphadenopathy. They're literally telling you here it's granuloma, right? We can look at it. We can see it's a non-caseating granuloma. Okay, so these are the clues to kind of point us in the direction of sarcoidosis. But then the next step is, what is exactly going on in sarcoidosis? Okay, so let's kind of talk about that. And how is that related to a hypersensitivity reaction? Well, remember, in sarcoidosis, we kind of go back to our T helper 1 response, right? If I'm going to form a granuloma, for example, even if I didn't know the pathophysiology of sarcoidosis, if I understand what's happening from an immunologic perspective, right, by understanding the hypersensitivity reactions and granuloma formation, I can answer this question. The concept here is, right, just kind of going back to this, if I have some antigen presenting cell, I'm just going to say this is a macrophage. That's what this denotes here is macrophage. So this macrophage, right, it's going to digest a pathogen normally, right? And let's just say we're talking about tuberculosis. Now remember, tuberculosis causes caseating granulomas, but I just want to kind of start here with this example, and then I'll tell you what's happening in sarcoidosis. But again, if we're taking tuberculosis, right, so this macrophage is going to present this antigen after it kind of phagocytoses it, right? And in the case of tuberculosis, we might not know what to do with it, so we start to wall it off, right? But anyway, we're going to present this antigen to a T cell, okay? So this is usually going to be a naive T cell, okay? So this naive T cell is going to see this antigen, right? This is its specific antigen. It's going to match up its epitope. It's going to bind to the epitope. And then this T cell becomes activated. And how does that happen? Well, that's because this macrophage tells this T cell, hey, I want you to become a T helper 1 cell. And how does it do that? It sends a signal using interleukin 12, right? We talked about this a few times. And then there's an interleukin 12 receptor on this T cell that allows for this interleukin 12 to bind. And that allows this T cell to become a T helper 1 cell. And then that T helper 1 cell can also stimulate this macrophage by releasing interferon gamma. Now that we have this T helper 1 cell, it can go on to release interferon gamma to this macrophage to activate this macrophage. And this activation can allow these macrophages, right, to become epithelioid cells or multinucleated giant cells. And then just like we said, these epithelioid cells would be present here around the granuloma, as well as these multinucleated giant cells. And so this is basically what's happening in the case, like we said, of TB. Now in sarcoidosis, what's happening in sarcoidosis is that we have kind of a dysfunctional T cell response. So we have a lot of these T helper 1 cells becoming activated, even though we might not necessarily be presenting a infectious pathogen to them, right? So there's some dysregulation in this T helper 1 response to the point where this might be potentially overactivated and then stimulating too much interferon gamma to cause these macrophages to then become activated and become epithelioid cells and multinucleated giant cells. Okay, so in sarcoidosis, the pathophysiology has to do with granuloma formation, meaning that it must involve T helper 1 responses with interferon gamma, right? And we can tell that just from looking at, if you just looked at this image and recognized, hey, this is a granuloma, or you saw that, hey, this is a granuloma, right? How do granulomas form? Well, typically, this is going to be from a T helper 1 response mediated through interferon gamma release. Okay, so again, understanding the mechanisms is really the key for step 1. You don't necessarily have to clinically know exactly what to do next or what the next best test is, right? That's more of a step 2 thing. But the key here is understanding the mechanism. Now remember, this is going to be more related to a type 4 hypersensitivity because this is more of a T cell mediated process. Now let's just go through the other options here really quickly. So option A, FC receptor mediated immune cell activation. So typically what this is talking about, like if I had let's just say I had an autoimmune hemolytic anemia, right? So in the case of autoimmune hemolytic anemia, I might be targeting an antigen on the surface of my red blood cells, right? Maybe there's some antigen here, and my antibodies, let's just say I have some IgG antibody here that's going to target this antigen. So this IgG antibody is going to bind, right, using its Fab portion here to this antigen. And then out here, I have my FC portion. So this FC portion can then bind to an immune cell, can activate complement potentially, right? And that can lead to activation of immune cells to destroy this red blood cell. So this would be very classic for a type 2 hypersensitivity reaction, right? So this would be classic for a type 2 hypersensitivity reaction in that we're causing immune cell activation using the FC portion of our antibody, right, to activate some immune cell to destroy, this target. In this case, it's the red blood cell in autoimmune hemolytic anemia. It could be a platelet, an immune thrombocytopenic purpura, for example. And in both of those cases, that would be a type 2 hypersensitivity reaction. And again, just going back to option D here, remember we said this is usually going to be type 4 hypersensitivity reaction. All right, let's just go through the other ones here. Option B, IgG-mediated inhibition of signaling pathways. So you can imagine, right, if I had, let's just say I had a synaptic cleft here. So here's my postsynaptic membrane, here's my presynaptic membrane, right? I have these acetylcholine receptors. If I have a condition like myasthenia gravis, right, I can actually have antibodies that literally physically bind here on these acetylcholine receptors. These are anti-acetylcholine receptor antibodies. They can physically bind here and block acetylcholine from binding to this receptor, right? Because this antibody is physically sitting on the receptor. This is also an example of a type 2 hypersensitivity reaction that we've talked about in this chapter. IgE-mediated mast cell degranulation, right? So again, we have IgE receptors on the surface of our mast cells, and we've kind of gone through this a few times, so I won't go through it again here. But essentially, this is going to be classic for a type 1 hypersensitivity reaction. These all really are not completely relevant to the formation of a granuloma, right? We've talked about that before. So a lot of these other options are kind of out of the scope of what you would expect to see in a patient with sarcoidosis. The final one on here, you can probably guess, is a type 3 hypersensitivity reaction. This is where we get deposition of antigen-antibody complexes. Again, not very classic for sarcoidosis, right? This is something you might see, classically in a patient that has something like a post-strep glomerulonephritis. So just to recap the big point here, a lot of times test writers are going to make you think a little bit. Okay, so sometimes you got to think outside of the box to figure out what's going on. If you didn't memorize that sarcoidosis is a type 4 hypersensitivity reaction, just kind of think about what's going on, right? If I know the mechanisms, I go back to the mechanisms. That's what I do when I'm in a situation where I really don't know where I'm supposed to go with the right answer here. And the fact that I know there's a granuloma, I have to think about how granulomas are formed to get to the right answer. And again, like we've kind of talked about in some of the other videos, there's going to be things in here that are going to try to distract you. Well, why does this patient have, worsening anxiety? And why does she have weight loss and this cramping, non-specific abdominal pain and then diffuse joint pain? What's that all about? And a lot of this stuff, sometimes test writers will put this in here to throw you off, but the thing you have to understand is there's usually a reason for it, right? For example, this patient has sarcoidosis. Why does the patient have anxiety? Why does the patient have bone pain? Why do they have abdominal pain? Well, remember what we said, right? In sarcoidosis, and we'll talk about this more in the room section, but in sarcoidosis, the problem here is that once I get these epithelioid cells and these multinucleated giant cells, the problem is we start upregulating 1-alpha hydroxylase. Remember what we're talking about here, right? We start with cholesterol, right? And we eventually get this cholesterol through the liver, which turns it to 70-hydrocholesterol, UV light, et cetera, et cetera. Eventually, the liver turns this cholesterol into 25-hydroxyl D3 for vitamin D, right? And it does this using 25-hydroxylase. Now, this form of vitamin D is more of a storage form. It's not the active form of vitamin D. In other words, it doesn't exert the effects where we can increase calcium absorption and phosphate absorption, for example. So what we can do is we can store some of this, 25-hydroxyl D3 in the adipose tissue, for example. But then what we can do, if we wanted to activate this, normally this 25-OHD3 can then go to the kidney, right? And in the kidney, we normally have this 1-alpha hydroxylase, and this can turn it into 125 vitamin D. Okay, so the point is this form here, this 125, this is the active form. This allows for increased calcium, right? So this vitamin D is going to allow me to have calcium reabsorption. And again, the point here is with sarcoidosis, remember we said these T helper 1 cells are going to have some dysregulation, right? I'm going to have too much activation of my macrophages getting converted to epithelioid cells. And then all of these epithelioid cells are going to start to release too much 1-alpha hydroxylase. And all that 1-alpha hydroxylase, guess what that's going to do? That's going to cause more conversion of all this stored 25-OHD3 into the active form of vitamin D. And if I have too much of this getting turned into the active form, well, guess what's going to happen to my calcium? It's going to go way up. And what happens when you have really high calcium levels? Well, when you have really high calcium levels, usually, and the mnemonic that's classically remembered is going to be bones, stones, groans, and then I'm just going to put POT for psychiatric overtones. Okay, so the bones is usually talking about bone pain from the hypercalcemia, stones, so nephrolithiasis, right? Groans, usually abdominal pain from the hypercalcemia, and then psychiatric overtones, that might be, right here we see some of that anxiety. And so we can see a lot of these symptoms, right? The abdominal pain being the groans, the diffuse joint pain potentially being the bones. So there's other symptoms here that we can actually correlate to the hypercalcemia, secondary to the activation of vitamin D, secondary to these epithelioid cells, right, that are classic for sarcoidosis. So again, there's going to be things in the question that sometimes you might not make all these connections with right away, but as I always say, the most important thing to read is usually going to be the very last line, which is where the question is at, and then working back. What is going on, everybody? In this video, we're going to talk a little bit about transfusion reactions. Again, this is kind of like the hypersensitivity syndromes, the immunodeficiencies, the transplant rejections. There's kind of just a bunch of different categories of pathology that you should be familiar with. And a lot of these can be distinguished based on some very unique things, either in the presentation, the diagnostics, or the management. And so we'll start here with the acute hemolytic reaction. Now, the acute hemolytic reaction is probably the highest yield of the group. And so that's why I think it's a good one to start with. But not only that, I think this is a great opportunity to just kind of talk about these red blood cells and review what antigens are typically going to be on the surface of our red blood cells. And when we talk about the different red blood cell types, right, we have different groups. So we have group A, group B, we have a combination A, B, and group O. And what this is referring to, what this A is referring to, is just this antigen here on the surface of the red blood cell. So these red blood cells have an antigen that we'll just call the A antigen, which means, again, if this is an antigen, right, potentially if I had an anti A antibody, right? An anti-A antibody, that antibody could potentially bind to these antigens and then mark them for destruction. And this is exactly what we talked about when we talked about type 2 hypersensitivity reactions. We had antigens that were on the surface of cells that antibodies bound to and then marked those red blood cells for destruction, primarily mediated by complement. And so that's the concept here. So these red blood cells, this group A,